It leads to failure early in life, also in the first 1 year of life, leads to renal tubular dysfunction, neurological manifestations, and is one of the causes of early hepatocellular carcinoma in young children. The treatment of this disease is oral tablets called nitisinone. It's quite expensive, but it is a simple treatment. The last example is cystic fibrosis, is a multi-system disease that affects the chest, recurrent chest infections, bronchiectasis, chronic diarrhea, affects the liver, cause fatty liver, fibrosis, portal hypertension, pancreatitis and pancreatic insufficiency, infertility, growth failure. And the management is just nutritional management, pancreatic enzyme replacement called Creon, oral medication, and CFTR modulators, which is an oral medication as well. So the clue here is which disease is appropriate for screening. It should be a serious disease that has relatively high prevalence, and the treatment should be available. I will not screen for a disease that doesn't have a treatment. So the aim of any screening program is to diagnose the disease before symptoms, to reduce mortality, reduce severity, improve quality of life, and increase choice at an early stage of life course where more options are available. Screening is like a sieve. The whole eligible population should go through it to identify those with the condition. So this brings us to what's the characteristic of a good screening test. A good screening test should be inexpensive, easy to administer. The newborn screening test is just a heel prick to get a blood spot, put it on a filter paper, and then the tests for these 19 disorders will be done from this dried blood spot. So it is easy. Minimal discomfort for the patient, should be reliable and valid. And when we talk about validity of a screening test, no screening test is 100% accurate. The ideal screening test would have 100% sensitivity and 100% specificity, but this is not the case, never. We always have this part of false negative and false positive test results. And when we talk about sensitivity and sensitivity and specificity, this is written wrong, sensitivity and specificity. To make it easy to remember, a sensitive test is a good negative test, and a specific test is a good positive test. You can remember with sensitive with an N is a good negative with an N, specific with a P is a good positive with a P. For a screening test, I need it to be sensitive and specific, but I need it more to be sensitive. I don't want any false negative results in a screening test, because I don't do further investigation for a negative result. If it's negative, I should trust this negative. But if the result is positive, I will do further investigation to know if it's a true positive or a false positive. But it should be a screening test, its negative result should be trustable. So it's very important for a screening test to be sensitive one. Back to hepatology, the biliary atresia is the most common cause of pediatric end-stage liver disease. It's the leading indication of pediatric liver transplant. It presents with cholistasis, clay-colored stool, and hepatomegaly. The gold standard for diagnosis is liver biopsy. Without treatment, this patient will develop liver failure within the first year of life and will die within maximum 2 years. The management of biliary atresia is surgical. It's called Kasai-Porto enterostomy, done within first 2 months of life. The earlier, the better. Maximum is 3 months of life. And it's a bridge operation to liver transplant, but some patients may not need a liver transplant. Can we screen for biliary atresia, this common disease and very serious disease? Trials for screening are the stool color card. We show this stool color card to the caregiver in the well baby check visits. If the color is within this range, it's normal. Within this range, this is pale stool that needs further investigation. Another test is conjugated bilirubin in the first month of life. The problem is in Egypt, we don't bring the newborns to the primary healthcare center except in the first week for the heel prick, and then at age 2 months for the vaccination. And screening for biliary atresia at 2 months is too late. And till this moment, there are trials of doing bilirubin in the dried blood spot, not in serum. So until we have a screening test for biliary atresia, please take this message home. Maybe you encounter a baby with jaundice. If a baby with prolonged jaundice, and I mean prolonged that he has jaundice beyond day 14 of life, please do serum bilirubin total and direct. And if the direct bilirubin is 20% or more from the total, this is cholistasis. Please refer to a pediatric hepatology for further investigation to exclude this surgical emergency called biliary atresia. And thank you.